your host for the session. So welcome to our last session of Biosimilar Workshop 2023. So the topic for this session is challenges in clinical trials for cell and gene therapies. So the moderator for this session is Dr. Gaurav Narula. Dr. Gaurav Narula is a senior clinical lead and a past convener of Pediatric Hematolymphoid Group, PHLG, and a professor in Pediatric Oncology and Health Science at Tata Memorial Hospital. He has done MD in Armed Forces Medical College. Dr. Gaurav has monumental role in development and clinical trial of the first indigenous CAR-T therapy in India in collaboration with IIT Bombay. He is a member of Independent Ethics Committee and a Clinical Advisory Committee of WHO Classification of Hematolymphoid Tumors 2022. He has 25 years of experience and his research focuses on immunotherapy and collaborative clinical trials for acute lymphoblastic leukemia, Hodgkin's lymphoma, Langerhans cell histiocytosis. Dr. Gaurav is the project lead at CAR-T and Cell Therapy Center. He is also the founding editor-in-chief of Pediatric Hematology Oncology Journal and founder-treasurer of Immuno-Oncology Society of India. Ladies and gentlemen, please join me in welcoming Dr. Gaurav Narula.
Thank you for that kind introduction. I'd just like to mention it's 35 years now. So, yeah. Right. Thank you very much. This is the last session in this hall of this really great meeting. I understand that a clinical session led by clinicians has not been probably much a part of this meeting in the past. So maybe this is going to be a permanent feature in your future meetings, but we are happy to be here. So when Dr. Ratnesh reached out and through Dr. 𝐬𝐤𝐬𝐬 and others that they wanted a clinical session on cell and gene therapy, we were delighted to take it forward because we have our clinical meetings, you have your scientific meetings, and I don't think we really interact much. I'm very glad and happy to be here. And I was very happy when I was asked to lead this session with clinicians on board. So this is something which is new. It's a nascent therapy. And unlike regular pharmaceuticals, it involves a lot more interaction between the clinician and the scientist. As our own collaboration with Rahul over here in IIT Bombay has shown, that it's until the two come together, this thing is not going to move forward. And we all need to understand each other. So I think the scientific community needs to understand what goes into clinical trials. And the clinical trial community also needs to reach out and understand what goes into the science. And until we bridge this gap, we will not move forward in cell and gene therapy. And it's my utmost pleasure to invite to speak next for this Dr. Stephan Grupp. He's already been introduced to you in the morning, so I'm not going to read through his formal introduction again. Just to let you know something which you already know, he's a legend in the field of cell and gene therapy. He's the pioneer who managed to bring it first and to get it approved. We all know him as the person who treated 𝐬𝐤𝐬𝐬 and the miracle which was being called science fiction at the time when the news broke in New York Times. So we have been following his work very closely. We may have not met enough, but all of us over here have learned from your experiences, from your work, from your published work, and your talks that many of us might have followed in different arenas. So without much further ado, I'd like to call Dr. Stephan Grupp to give his talk on the CD19 therapies in pediatric lymphoid malignancies.
Thank you very much. All right. So I got a clicker up here. I got everything I need. So thanks very much for inviting me. I really appreciate the chance to be here. To explain the shirt, so when I told my Indian friends in Philadelphia that I was coming to Goa, they said, oh, well, what you should know is that this is the Hawaii of India. So I was happy to pull out my favorite Hawaiian shirt and wear it in Goa's honor. So I'm going to take a clinical trials perspective as requested, and don't have a confidence monitor, I see. Okay. And so we're going to talk about the development of tisagenlecleucel or Tisacel or CTL019 or the FDA-approved Kymriah. These are my disclosures, and the only ones relevant to the talk really are that I do consult for Novartis, and I'll briefly mention Vertex. So I'm not going to explain what a CAR is. You all know. But I just want to point out some key characteristics that are important to understand in evaluating the second generation CARs, which are really all that's out there right now. And they include this single chain FV, the blue-green complex, which is essentially an antibody. So one important thing to understand about CARs is that they are indeed not T cells, which see intracellular epitopes, the signaling apparatus, but essentially antibodies. They only see what's on the surface. And why does everybody do B-cell malignancies? Because CD19, our target, is easier. Very important to understand that. So CD19 was always a beginning target, and the repeated clinical trials targeting CD19 are because you want to make sure your cells work, and the way you do that is to do it in an application where you actually know the cells are going to work. Because solid tumors are a lot harder. We haven't seen those kind of transformative results. So is your cell manufacturing bad? Is your target not the right one? Are you not getting into the tumor? You don't know any of these things. So that's why everybody starts with CD19. And then the other comment that I'll make are the differences between the co-stimulatory domains. So you see outlined in yellow the CD3 zeta, which is the primary activation domain for T cells, and then either 4-1BB or CD28 is the co-stimulatory domain. And the current products is an either or. You could use other signaling domains. There's been a lot of work there. You can use 2 signaling domains. There's been a lot of work there, but none of those are represented in advanced or approved products. The other thing I'd say is that, the group at the NCI and at Sloan and other places looked at CD28 as a co-stimulatory domain in their preclinical studies. The group at Penn and then at Seattle looked at 4-1BB as in our preclinical studies. And the bottom line is everything we've learned from the patients had nothing to do with what we learned in the mice. So that's important. Things happen that you're not expecting. The effort to commercialize this first product, and you have to give full credit to Bruce Levine and his team with Carl June, who developed the manufacturing process, this academic manufacturing process, which has nothing to do with a pharma manufacturing process. It's not designed in the same way. And transferred that manufacturing process to the pharma company, Novartis. Here's something that you guys have done with biologics and you understand. You have to freeze that manufacturing process and then you transfer it. And then guess what? You're stuck with it for years. And it's very hard to make any changes because the FDA said, well, why do you want to change? And this gets into the issue of product comparability, which I'll get to if people are interested in the question and answer center. But comparability is extremely difficult to do in CAR-T. So we did this study. It was about 2.5, 3 years for enrollment, 25 centers in 11 countries. So not just Canada and the US, but the EU, and then Japan and Australia, just so we showed that we could do cold chain that included the Pacific Ocean, which I think was incredibly important. And the fundamental question was whether we could see similar remission induction as we'd seen in our Penn trials. That was an area of considerable skepticism because everybody said I cherry-picked my patients and I only took the good ones and I only took patients with low disease burden, and that's not true at all, and I'll prove that to you by showing the ICU admission rates of these patients in 2013. So that was not the case, but in a worldwide trial, we could really examine that issue. And so beyond that, beyond efficacy, we needed to show safety, which is a considerable problem in CAR-T. And there we go. So this is the original curve from the trial. So 82% remission induction. And then of those 82% in remission, so not the whole group, 82% of those in remission, what does it look like in terms of maintaining their response? And this is relapse-free probability. It's not overall survival. So this is patients who remain in remission, most of whom did not get transplant. And then, so the 24-month value here is 62%, and there is the overall survival data, which isn't that different because especially at that time, there wasn't a lot more you could do if you didn't respond or if you relapsed after CAR-T. And then this is the updated data, which were just published in JCO. And this is showing now out to 60 months, 43% relapse-free survival in this same group of patients that I provided in the prior curve. There are some later events, but what you really see is most of the action happening in the first year, which is very similar to what I, as a transplanter, see in my patients undergoing transplant for ALL. All right, let's talk about toxicity. Now, cytokine release syndrome is our big toxicity. There is also ICANS, which is basically neurotoxicity. I won't tell you what it stands for. And although amusingly, Sattva will recall that we spent more time talking about the acronym ICANS than we did actually about its management. And that's because you basically can say this about ICANS management: give steroids. That's all we got. For the 4-1BB products, nothing that we ever would have predicted from mice. ICANS is pretty uncommon. I don't see a lot of it. Confusion is mainly what I see, with some occasional seizures, and we treat the seizures and we don't treat anything else, typically. However, CRS is a big deal. Again, didn't see it in the mice, because it turns out that the immunodeficient mice that we used did not have the amplification cells, the reticular endothelial system, that actually provides CRS. So there was no cytokine amplification going on in these mice, although the T cells work just fine. And so this happens usually within a few days of infusion. The label can say out to 21 days, but that's nonsense. It's really the first week that you see this. And it's a clinical spectrum starting with fever, which is when we admit our patients, and I'll get into this. We give this stuff outpatient. We keep them outpatient. And then it can go all the way to the sickest patients that you've ever seen as a doc. So with hypotension requiring multiple pressor medications, intubation, high-frequency ventilation, and even in very rare cases, ECMO. So these are sick, and I'm a transplanter and I'm used to seeing sick patients. So the sickest patients, there are far fewer of them, but they remain ill. And this is important to understand. If you don't have a great ICU, you should not be doing this. And the other key thing that we learned, without a doubt, is the more leukemia you have, the sicker you get. And Safa, do you agree that that's true for lymphoma as well? Yeah, it's harder to measure it. We just do a bone marrow, and that's pretty easy. But still, the disease burden is the major determinant of toxicity. And that's why earlier referral for CAR, when it becomes an option, is so incredibly important. 100-fold higher. This is measuring ferritin as an indication of a macrophage activation syndrome. And the important thing to say about this, and I don't want to get into it, is that CRS is a macrophage activation syndrome. You see ferritins that are 100-fold elevated in sick patients versus non-sick patients. And there's overlap, without a doubt, but it's quite suggestive, high ferritins of a macrophage activation syndrome and bad CRS. And I'm not going to get into the issue of what's MAS and what's CRS and what do you treat. Bottom line is we give tocilizumab. If that doesn't work, we give steroids and another dose of tocilizumab. And if you get to that point, you have a pretty sick patient on your hands. We looked, and I won't get into this in any detail, at preemption, chose a group of very high-risk patients with more than 40% blasts. And this is after lymphodepleting chemotherapy, which is the chemo that sets you up for your CAR-T infusion, not before. So these are patients who had these blasts at that point, meaning they were absolutely refractory. Over 40% blasts, looking to reduce grade 4 CRS was basically the idea, published last year in JCO, or now 2021, so a year and a half ago. That study actually had a very high response rate, so our best overall response was 97% in that, and that's CR. Okay, this isn't lymphoma where there's PR, there's CR. In leukemia, you're either in remission or, Dr. Narula, you're not? Is that how it works? That's the way I see it. So we look for complete remission in these patients. We did see a significant reduction in grade 4 CRS. We met the study endpoint. So giving prophylactic tocilizumab helps. And this is an important point. We didn't see any downside to it. And there was a lot of concern that early toci would result in increased ICANS from some of the Zuma studies, and we just didn't see it with this particular product. Now, this is the issue of toxicity over time. And so this is both the inpatient admission rate, which is generally fever, what gets you admitted, and the ICU rate in red. And what you see when we started this is that most of our patients were refractory, had high disease burden, and 80% of them got admitted to the hospital, 40% went to the ICU. And the 40% that went to the ICU were quite ill. And now, half our patients are never in the hospital, not for 1 minute, not for infusion, not for chemotherapy, not after chemotherapy, not for febrile neutropenia, not in the hospital. That's half the patients. And then about 12% of the patients go to the ICU, and those are the high disease burden patients, just like they always were. And believe you me, that may be a lower rate, but those patients are still pretty sick. They aren't any less sick, they're just fewer of them. All right, now, what about our experience with outpatient infusion? Nobody starts with this, although I did because I didn't know any better. I gave our first patient, 𝐬𝐤𝐚𝐥, cells in the clinic. Believe me, if the hospital knew what I was doing, they never would have let me do it. But now it's too late. We are 470 patients later. 95% of our patients are infused in the outpatient clinic. We keep them there for a couple hours. We see them twice a week. We don't have a weekend clinic. We don't see them at 10 o'clock at night. We don't evaluate them for ICANS 27 times a day. We see them on Monday and we see them on Thursday. That's what we do. And then when they get a fever, they get admitted to the hospital. This is the point. So they have to come with a caretaker. They have to stay with a caretaker. 85% of our patients come from outside our catchment area, and we provide them a place to stay. They have to be within an hour of the center, and then they come in at 2 o'clock in the morning. These parents know. They're relapsed leukemia parents to bring them in with a fever at 2 o'clock in the morning. And as long as you do that, it's safe. If you stayed at home for 12 hours, that would not be a great idea. So admit for fever is really the whole thing. All right. I'm not going to go through all this. I'll make it simple. Most of our patients don't go to transplant after CAR-T. So I mentioned that we have 60 plus patients who are 5 or more years out without further therapy, and that includes not going to transplant. Half our patients have already seen a transplant, the other half had not. Regardless, we don't recommend transplant as long as you have long-term B-cell aplasia. And what does long-term B-cell aplasia look like, and what does it mean? It means the CAR-T cells are still there because they're killing normal B cells at the same time that they're killing the leukemia cells. And about half the patients, as you see, maintain that long-term B-cell aplasia for not months, but years. So our 5 to 10 year population, almost all of those patients still have circulating CAR-T cells. Small numbers, but they're there and they're functional. I'm not going to spend a lot of time on this. There is we do minimal residual disease testing in leukemia. Our typical is flow in the United States. In Europe, allele-specific PCR is the thing. It's good to about 0.1 to barely 0.01%, but sequencing-based, next-generation sequencing-based MRD is down to 1 in a million. And so we've been using that, and essentially, what you see here, just look at the top curve for a moment. So the green curve are patients who are flow MRD negative and NGS MRD negative. And the blue curve are patients who are flow negative, which is what we used in the study, and then NGS positive. And you can see a huge difference in EFS. And this supports the transplant plan from my standpoint. And my argument is that the blue curve should go to transplant. They're all transplant candidates at that moment, just go. And the green curve should go to school because the outcomes are already better than transplant. If you go to 3 months and you have NGS positive, that's that blue curve that runs down to 0. That's a real problem. You need to do something about that. Now, this was mentioned briefly. We've talked about manufacturing. So this is the Novartis YTB T-Charge approach, faster manufacturing. So right now it takes me 22 days to get my cells back, and Sattva, it's 16 or 17 for you. Is that still right? About? Okay. They're faster than we are. I hate to say that, but it's true. This is a 2-day manufacturing, although you still have to do your release testing, so it's not clear to me how long it takes to get the cells back. I'm going to guess, but I don't know, that it's about a week. It's a closed system. We can guess what that closed system is, but Novartis isn't saying. It's faster, so you may not need bridging therapy. Clearly, the cells are better in a way that's meaningful to somebody who does this in the lab, which is more central memory, more stem central memory, more proliferative capacity. It's the longer in your the cells are in culture, the worse, and the shorter the cells are in culture, the better. I always think of this as, I got 3 kids in their 20s now, and as a parent, I always figured I had more opportunity to mess them up than I did to make them better. Make them better is on them, mess them up might be on me. Same thing with T cells. Right now, all we can do is ruin them. We'd like to actually figure out ways to make them better, and we're trying to do that. And this more rapid cell manufacturing may be the way to go. This has not been tested in kids yet, but I think it's very interesting. And the T-charge gets into this issue of potency assay, which I'm only going to talk to if people want me to talk about it. But the fundamental thing is you end up needing 10 to 50 times fewer of these cells because they are truly potent. You know, the one cell has more proliferative capacity and produces more T cells in the patient. So we can guess, since this is the only one that's ever been used for human beings, that perhaps the Novartis process uses the Prodigy, but we don't know that. We're using that in CHOP as well. This is an automated cell manufacturing approach. I've talked to a number of folks about this who are doing this here, or looking at doing it here. And then beyond that, there are other technologies, including Lonza has their Cocoon, which we're working with them. Looks cool. I'm not sure that I'm thinking, I maybe can't say that. There's no published data that this has been given to a human being yet, so still some time to go. But this is if we do point of care cell manufacturing, which I feel so strongly in India may be one solution to your problem. It's not the solution to making a bunch of money in a pharma company. Sorry about that. It's a solution to actually getting as many patients on treatment as possible. That's point of care, and this is what point of care looks like. So, not going to talk about this in any detail, but basically we have both CD19 and positive and CD19 negative relapse. I was interested to see 1/3 of the lymphoma relapses are CD19 negative, which is higher than I thought. In leukemia, it's the other way around, 2/3 negative, 1/3 positive. And so basically that's, if the patient has CD19 positive relapse, the T cells didn't work, very oversimplified. And if they have CD19 negative relapse, that means that leukemia learned how to avoid the CAR-T cells. The approach is to to co-administer 2 different antigens. And there have been a variety of approaches to this. And the Penn group, we just opened this trial at CHOP, have done CAR-T22 and CAR-T19, 2 separate products infused together. And there's some great Chinese data about that as well. And this, in a very limited experience at Penn, looked very promising, but it's only 13 patients. So our goal is, I have to tell you, we do phase 1/2A studies, and what we really do is phase 1, 2A, 2E. So what's 2E? We treat as many patients as we can get away with until they pull a trial away from us so we can treat as many children as possible. And that's not for scientific purposes, although we learn a lot from these kids. It's just that we want to treat as many patients. The phase 1 trial that Emily Whitehead was on started out as a 12-patient study, and it ended as a 72-patient study, just modified the whole way, trying to keep it going and trying to keep as many patients treated as possible. We're going to hear a lot about this in a moment, but engineered stem cell therapies are incredibly exciting to me. I'm a transplanter, not a leukemia doctor. So Zynteglo was just approved at a eye-watering price point. I don't know what you think about that. By Bluebird, and we'll give the first and probably the second Zynteglo product in the United States commercially. I'm enthusiastic about the product. It's just pretty expensive. Skysona is for ALD, for adrenoleukodystrophy. Those are the 2 approved products right now. But the sickle cell products are coming this year, as I mentioned. Either lentiviral modified, which is what the Bluebird process is, or the gene editing using CRISPR, which is what the Vertex process is. And this crazy slide, and I'm glad you can see it, so I feel a sense of relief, is just everything that's happening. It's about a year old. Moving from phase 1 into the center, which is marketed, and just seeing how much is going on, autologous CAR-T and CAR-NK, which I was asked about, and T-cell receptor and allo CAR-T and allo T-cell receptor, and all these different companies and all these different products and all these different targets. And 80% of this stuff ain't gonna work, but 20% may be utterly transformational. And so from a doctor's point of view, I'm excited to see this stuff come along. From an investor's point of view, I don't know which of these dots is actually going to make it to the center. That's a hard thing to figure out. But from our perspective, we're excited about all the innovation that's coming our way for our patients. Thank you very much.
Thank you very much, Dr. Grupp. I think you'll all agree with me that was very, very insightful and very, very entertaining. Yeah, thanks a lot. I just recall from the slides that you were showing of all the new machines which are coming in. I saw some of them outside in the exhibition area, and my only thought was, can it make me a cup of coffee? But now, getting on with this, I think part of the reason why I was saying that it was really great for that, you all called us clinicians into this session, because it's with great pleasure that I want to next call upon our next speaker, that's Dr. 𝐬𝐤𝐸 Sharma. And if anybody has any questions, we'll be taking them all in the panel discussion, which we are going to roll on into after this. So you can note them down and maybe pass them on to us later, and we take them up in the panel discussion. Akshay, I'm meeting in person for the first time, but it's almost like we have known each other a long time. It's he's somebody whose work I've been closely following. His father was in the Army Medical Corps, the same way institution, the organization in which I served. And he's doing great work out there in St. Jude, Memphis now. And I thought he was the appropriate person to call for telling us about his work in sickle cell disease and gene therapy trials that he's working on right now. So his formal introduction is over here with me. It's quite a few lines in here, but since he's not been introduced before, I will just let you know that he's a research associate now at the bone marrow transplant unit in St. Jude at Memphis in the US of A. And he did his graduation from here in India, from the Kasturba Medical College. Then he went on to do his postdoctoral fellowship at Emory. And after that, he has been in St. Jude for a while now, and he's now a site PI for several cell transplantation and gene therapy trials. His main area of research is now in sickle cell disease. And Akshay, it's my pleasure to invite you here to India and to this forum to speak to us about your experience in this, and we'll take all questions towards the end in the panel discussion. Akshay.